Welcome to Home Health 360, a podcast presented by MGA. I'm your host, Jeff Howell, and this is the show about learning from the best in home health care from around the globe.
Hi, folks, and welcome to another episode of the Home Health 360 podcast, where we interview home health professionals from across the globe. I'm your guest host, Erin Valier, SMB Sales Director for MGA Software, and today I'm joined by two professionals from MGA Homecare, Hani Feldman and Alex Kalauskas, to talk about private duty home care services in the pediatric space. Hani is the CCO, which stands for Chief Cooking Officer in her home, but at work, she is the Chief Clinical and Government Affairs Officer for MGA Homecare. She started her healthcare career as a nurse in the NICU at Children's National Medical Center in DC, and then moved into the home healthcare space about 15 years ago. She served in a variety of roles, from clinical director to clinical educator to working with the CEO on a process improvement team to government affairs and public policy. Wow, that's a lot. Currently, Hani advocates for the medically fragile population who receive care in the home. She's obsessed with making a case for home care and shouts from the rooftops that this is the highest quality, lowest cost setting to deliver care. I agree with you. So welcome to the show, Hani.
Thanks. Can't wait to be here.
Yeah, I'm excited to have you. And Alex has been with MGA Homecare for approximately a year on the government affairs team and recently moved into the Chief Compliance Officer role. She's a licensed healthcare attorney who began her career representing California Medicaid clients who had been denied services. After law school, she moved home to Colorado to work for the Governor's Office of Legal Counsel and then the Colorado's Medicaid agency, that's HCPF. She managed the home, community, and maternal health benefits section for about 6 years. At MGA, she plans to use her expertise to support the organization's caregivers in delivering the best care possible to the medically fragile children they serve. Welcome, Alex.
Thank you. Thanks for having me.
So excited. Well, you ladies both have a really impressive resume, and I can't think of anybody else I'd rather talk to about what's going on in the pediatric space today. So I'm really excited to have this conversation. And I'm curious, pediatrics is not for everybody. These kiddos are like really fragile. At least in my experience, it's like they're good, and then they're really not good. So it kind of frightens a good percentage of people away from that niche. So I'm curious about you guys. What drew you to the pediatric space? And can you share that Cliff Notes version with our audience today before we just dive in?
Sure. Hani, should I start?
Sure.
I think you covered it a little bit, and I apologize. I talk with my hands, so it's sometimes distracting on Zoom calls, but I'm sure on a podcast. But you covered a bit of my what pushed me into pediatrics in that little bio. I started getting interested in health law broadly in law school, which, that you really kind of got to pick an area of law pretty quickly. And the health law clinic, the elder and health law clinic to be specific, was an area of interest of mine. I had a supervising attorney who I really bonded with, and she kind of gave me that first experience with working with clients in the clinic, which was a part of law school that you don't really see in the day-to-day class grind. So I kind of fell in love with just the healthcare space and topic because of her and because of that clinic experience. And then after that, I was desperate to get home to Colorado and ended up after a couple different places at the Department of Healthcare Policy and Financing, which is HCPF is the acronym here in Colorado, where I started out managing the home health benefit and ended up supervising or managing a unit that oversaw like 15 fee-for-service Medicaid benefits, most of them very pediatric heavy and specific. So spending 6 years kind of running the programs there and how pediatric heavy they were kind of kept me in the space and kept me motivated and excited to continue doing that hard work. And then I was introduced to Hani and Brad, our CEO at MGA, and just kind of, I tell the story that it was kind of the cosmic push in the back to kind of move over to the private sector and to MGA, who's a great pediatric healthcare provider. So that's kind of how I've landed and stayed here.
Nice. That's a wonderful little journey. And back to Colorado, which I don't blame you.
Yes.
Not one bit.
Beautiful.
How about you, Hani? How did you land here?
Well, I, as you had mentioned, I started as a NICU nurse. So that I would say you'd think that would be this sort of natural transition into the pediatric home care space. But I can't really say that I knew much about home care at all when I was a NICU nurse. And if it wasn't, for a recruiter that, really was very persistent in getting me to come into an interview, I don't know that I would have known so much about home care. I specialized in a micro preemie team. So these were like 23 and 24 weekers born, months before they were supposed to. It was very adrenaline filled and it was a high paced environment. And, most of those kids, so many of those kids don't make it. I mean, there's tremendous advances in, medical technology, which, a lot can now, but often those kids, when they go home, if they make it through their journey in the NICU and they go home, they typically need home care services, but I wasn't aware of that. I mean, we would, get the memo from the charge nurse that morning, so-and-so is going home today. And we'd, go to the bay and kind of see them off and, wave to them in their car seat as their parents were taking them home, often with on a ventilator and with equipment, but didn't really think about how do these families do it. And like I said, was recruited to a home care, didn't think that I would like it, stayed on PRN at the hospital for a bit, but my first visit with a patient in the home, and I'm going to try not to cry here, but I have told the story a bunch. You walk into a home and it looks like a regular home, like you and I would have, and you go upstairs. And I walked into this patient room, little boy, and, I remember the walls were blue, beautiful furniture. And you look over at the crib and there's this, beautiful little boy hooked up, with a trach, hooked up to a ventilator, a feeding tube, suction machine on, in the crib, tons of medications. And it was just striking to me. And I was able to, look around, see the parents, see the siblings, the healthy siblings that were there. And I can't say that it hit me at that moment, but certainly didn't take me long before I said, what we do in the home enables this little boy to be at home with his parents and with his siblings. And it's not a normal life and it is not an easy life, but what we do is really, it is life-changing for these families. So I would say, became very passionate about what we did and, really switched fully, left the hospital, switched, to home care as a clinical director, did a bunch of jobs, like you had mentioned, a lot of different great roles. That switch to government affairs was a big, huge switch. And I'll just kind of be vulnerable and tell my, complete and utter ignorance towards the government affairs. I did not know what that was, but our CEO at that time, Brad Bennett, he kept telling me, he says, I need you in government affairs. And I had no idea what he was talking about. And I mean, literally had no idea. I was a nurse. I knew how to start an IV and do a grade assessment and chart. I did not know what government affairs was. And I would say to my husband, I said, people in the government have affairs. Like that was the extent of my knowledge. And finally I just got up the courage. The CEO tells you he needs you somewhere. You just say, okay, okay, sure, I'll do that. But, not really knowing. And I finally said to him, I said, Brad, I'm not really sure I'm your gal for this. I said, I really don't have any experience. And He says, no, I'm going to, I just hired somebody, government affairs professional, 20 years in the industry. He's going to teach you everything. But he said, at the end of the day, when we want to speak to policymakers and legislators about our patients, I want that person speaking to be a nurse, because you've been there and you've been in the homes and you've done this. So it was, government affairs is not common sense for, for those of the listeners that, are involved in advocacy. They know it's a regulated field. It's not like it's just, it isn't common sense, but I learned, the rules, the ethics surrounding actual lobbying. And I've feel that with the, the great teams that I've worked with, coalition partners, with other providers in the industry, we've made a lot of great strides. So it's been a fun journey, and I'm thrilled to be at MGA. I'm thrilled to have a partnership with Alex, and her role as Chief Compliance Officer, but her background is regulator. For me, I'm the passionate nurse that wants to change the world, and Alex is more of the the balanced. Well, these are the rules, and these are the these are the obstacles we have to face. So we've had a lot of fun so far, and we're excited to just continue to see a lot of change, good change, hopefully.
That's awesome. It sounds like I have the dream team, though, on the line today. So that's super exciting. And the CEO, he had some wisdom there. Who better to advocate for the industry than somebody who's been in it and knows it inside and out and can share that passion, because it is a special thing that you guys do. It's hard. I don't have a special needs child, but I can't imagine how difficult or nearly impossible it would be to care for someone without the proper team. And that proper team needs to be integrated into the home. And I know that MGA Homecare is a provider of private duty nursing services and also some therapy, correct? Like PTOTSD in the home. So share with our listeners, what exactly do these services entail? And can you tell me a little bit about the types of patients that you guys care for?
Yeah, absolutely. It's so private duty nursing, I would say it's definitely a misnomer. I had many meetings with different legislators that say, wait, what do you do? Private duty nursing? Is that like private pay for rich people? I mean, I've literally had those comments. Doesn't really describe the care that we provide. We look at it as hospital at home type of care. Hospital at home is actually talked about these days a lot as a new concept. And I we kind of get frustrated. We say, we've been doing this type of care for forever. Not forever, but since Katie Beckett's parents brought her home from the hospital. And I don't know if you know about Katie Beckett, but she was a 3-year-old girl who was stuck in the hospital because Medicaid wouldn't pay for her care. And just like the patients that MGA cares for, she was ventilator dependent. But then in 1982, President Reagan, with bipartisan legislation passed by Congress, created this Medicaid waiver that allowed for this type of care in the home. And really, the cost of keeping Katie Beckett at home was a fraction of what it was to keep her in an institution. It's typically a Medicaid benefit, and the regular employee-sponsored plans or commercial insurances typically don't offer this type of care. There are exceptions, but typically not. So our patients are usually technology dependent, as like in my example of, before with that first patient I saw requiring a trach to breathe, a feeding tube, or an IV for nutrition, a lot of medications to manage this, their conditions that they have. They have serious medical complications, genetic conditions that are not expected to improve. The exception are our kids from the NICU who were the preemies. They had a lot of complications. So like I had, shared earlier, they came home with this technology dependency. But we love watching them grow up and grow out of needing our services. And we celebrate their graduation from home care. And that is our favorite type of business to lose. The other types of patients we serve are those needing intermittent type of skilled nursing services. So, often not, they don't need the hourly type of care, the 8 or 12-hour shifts that we're providing for those technology dependent patients, but they need certain skilled nursing services. So we'll send an RN to a home to do those visits, 1, 2, 3 times a week, whatever it is. And as you had mentioned, we provide OT, PT, and speech for pediatric population, and we're about to start a behavioral health service line. So lots of great things we're doing in that space.
That's exciting. So you've got a the whole gamut, right? So from the medically fragile that require some intense care to the ones that just require a little bit of help a few times a week. And you said something that maybe Alex can expand on, that most of the benefits in the pediatric space come from Medicaid and rather than like private insurance. Why is that, Alex? Like why doesn't private insurance get on board here?
It's a very complex question and answer, actually, with a lot of historical components. But I would say the long and short of it is Medicaid is the only payer that will provide, continuous or pay for continuous one-to-one nursing at that hospital at home level of care. I think that's because of kind of the history of private duty nursing and how it developed as a benefit. It's an optional benefit, so not all state Medicaid programs have to cover it. States can elect to cover it or not. Most do because it's a cost-effective service delivery model and keeps kids out of institutions. But I think, the private pay space hasn't picked up on it largely, I would say, because Medicaid has been so robust in this service model in its reimbursement structure for so long that they don't really feel the need to kind of dabble there. They can pick up sort of the acute and the intermittent side, but they really leave it to Medicaid to cover the private duty nursing one-to-one continuous, high level of care.
That's interesting. I wonder if that trend will continue as we continue to focus more about care in the home. And I know in conversations that we've had, back and forth a little bit before this podcast, I've heard you say, honey, that the quality metrics and regulations that you guys are held to in the pediatric space don't really mesh, or they're more in alignment with adult home health. And even though on the surface level, what you've described to me sounds a little bit like adult home health. You've either got some people who are medically fragile, they require a lot of attention, or you've got the intermittent, 3 times a week wound care chain, or whatever. So on the surface level, it kind of appears like they're similar. But what you were telling me is that the regulations and the requirements and documentation that are applied to you guys are just not appropriate. So I'm wondering if you both can describe to the listeners how pediatric home care differs from elder care in the home, and how do you believe the quality metrics and regulations, how do you believe those should be tweaked so that you guys can operate more efficiently and more effectively for your clients?
Sure. I can kind of cover the first part of that question, and then I think Hani's best to speak to our kind of work on how we're trying to tweak them and make them more appropriate to pediatrics. But to start out, skilled care in the home was basically established as a benefit, and the regulations and the quality metrics that follow with establishing that benefit were all designed for the adult population, so 65 and older. And as payers kind of started expanding the coverage to include pediatrics in the home health space, because of cases like the Katie Beckett case that Hani mentioned, as well as the Olmstead and the ADA, different, whether it's litigation or acts of Congress or whatever it was that kind of opened the doors for these services to children, the combination of them. Really what happened was the existing regulations and the structure, the billing structure, pretty much everything, quality measures, as they existed for adults, were just kind of pulled over and applied to children. There wasn't a new development of a regulatory framework for children, even though these programs were expanded to allow them in. And what that's basically meant is we're left with acuity assessments, for example, and other regulatory requirements that were created for adults that don't really match the pediatric space or the needs of pediatric clients, as you described, Darren. So I think I always give these two examples because they're clear and kind of show what the issue is. But one is the OASIS tool. So I think most listeners would be familiar with the OASIS, the Outcome and Information Assessment Set, as that eligibility tool, that gateway functional needs assessment tool performed for Medicare home health patients. And that needs assessment tool goes into questions like, did the client read the newspaper today or this week? Is the client homebound, or are they able to independently leave their residence without significant assistance? Kind of questions like that. And those questions obviously answer a functional needs question for adults. So if an adult can't read the newspaper and they answer no, or they do need, they're unable to leave their house without assistance and they're homebound, then we know a bit more about that person's needs for skilled care in the home. But obviously those questions aren't applicable to children. Children can't read the newspaper and they leave the home all the time with the assistance of their parents. So that's just kind of, that is one example of, there's this federal acuity tool for the home health benefit, but it's really only applicable to adults. And in the vacuum, then for the pediatric side, states have kind of been left to establish their own assessment criteria for the home health benefit and the private duty nursing benefit as it applies to children, which has kind of led to like a patchwork effect. And then I think another example is the 60-day recertification. This is one that kind of highlights the regulatory framework. So I'm sure a lot of listeners are familiar with the 60-day recert. All, Medicare certified home health agencies have to comply with the conditions of participation. One of them is that we complete a recertification of the client every 60 days, which essentially means we're reaching out to their ordering physician or the non-physician practitioner to have them review the plan of care and the case file and kind of say, yes, this person is still homebound, or this person is still, needing X, Y, and Z services as you have them laid out. And that was really, that 60-day cadence really is built on and tracks the 60-day episodic care model of Medicare's home health benefit. So we have to comply with that. We have to do that for our pediatric patients, even though, and Hani can speak much more eloquently to the clinical component of this, but we kind of know in the pediatric long-term care home space that these children aren't experiencing a lot of differences in their care plan in a 60-day episode, so that we know when they come to us that they're probably going to be on services for a while, and reviewing their care plan every 60 days isn't leading to any better outcomes. It's kind of just causing us to have this administrative, to comply with this administrative burden, even though it's not, directly tied to something that's leading us to provide better quality care. So those are kind of two examples of how, Hani, do you want to expand on that?
Alex said I could say it eloquently. I kind of get irritated because I've been complaining about this in a very constructive way and also non-constructive way for a bunch of years. That 60-day reassessment, it's an RN has to go out to a home and do this assessment and come back, go log on, into the EHR, fill out the assessment, create a new care plan, send that to the prescribing practitioner. We have to wait for the prescribing practitioner to sign. There are rules around, how many, in some states, there are rules around how many days it needs to be signed by in order for, the plan of care to be effective. And it's paperwork. We don't gain, Alex said this, right? But it's just, I can't tell you all of the wasted time on this particular effort that could be better spent on actual care coordination, communicating with the payer, communicating with other social support services. And yet we have to go through this process every 60 days. We are not reimbursed any bit extra for that process. So the sending of the RN out to the home and all of the administrative burdens that are associated with that. And it is just, when we look at what's kind of dragging us down and we look at burdensome regulations. I mean, this is the example. And I've had this conversation, as I said, with legislators, with Medicaid directors, and I have never once had anybody say, I disagree with you. I mean, I've had Medicaid directors say, I wish we could switch this. This makes no sense. This is the best example of square peg, trying to jam it into a round hole. So anyway, we're working. We're trying to work with the different states to implement these, changes in regulations, quality metrics to address the pediatric population, and we're also trying to be engaged in a federal initiative which will create a pediatric portion of the conditions of participation, which governs, governs the care that we talked about. And if we could be successful in that, we would eliminate things like the 60-day recert, which, doesn't make sense. I just want to mention one other, advocacy effort that we are a part of. There's this ACE Kids Act, which is a bipartisan piece of legislation passed in 2019, and with a goal to improve care for children that are medically complex and those children who rely on Medicaid for their healthcare coverage. And under this ACE Kids Act, state Medicaid agencies are required to develop a set of quality metrics for children that will ultimately get approved by CMS. And we're really trying to get a seat at that table to be a part of that, to help craft these quality metrics, because children's hospitals absolutely are just such experts in knowing what is quality for these medically complex children, but home care providers need to be a part of that conversation as well, because we're such a huge part of, care for the children in the community.
Absolutely. And MGA is sort of a force to be reckoned with, and they have a really good team of people who are passionate about advocating. So I'm curious, is there a way for anybody listening that might be involved with a pediatric agency? Like, it seems like we need to band together on this initiative and have a really loud and unified voice if we're going to make some changes. Is there a way for folks to get involved with you or with the initiatives that you're involved with?
Yeah. I mean, Alex, do you want to speak, from the mind of a regulator, or, I could definitely also speak after.
Well, so there's a lot to tackle with the regulatory framework kind of being designed for adults, and how do it's federal. I mean, I think the answer for some of the COP stuff and that kind of level is obviously we need some federal legislation. We got to bend the ear of Congress to say this was established back when it was designed for this population. Like, look at the ways in which it doesn't make sense now. And here's some alternative ones that we'd like. So I think, I don't know that we have a specific, we are working with our lobbyists to kind of, craft one-pagers and get all sorts of historical information in place so that we can have this concept land, because it is a nuanced, there's a lot to take in, the history of Medicare and Medicaid, and then how it doesn't work for children in our current space. But I think other than that, reaching out to your representative, if you're a family member and if you're a provider, I think some of these coalitions that we've been a part of have been super helpful in just kind of having providers understand the regulatory landscape, share with each other what's creating a pain point, and then, getting kind of traction with initiatives to change things in a cohesive way. So
yeah,
that's basically how we've made our most headway so far.
Yeah, and we've been doing, as far as coalitions, we are part of PDN Coalition, which is, one of the, committees of the Home Care Association of America, led by Executive Director Vicki Hoke. She's been also a huge passionate advocate for home care and has, enabled PDN providers to work together on, just advocating for our medically fragile population. So our work, as part of that coalition has been terrific. But yeah, I love receiving emails and phone calls from providers and from families who, want to make a difference, want to make some noise on social media. I mean, because, as Alex said, for a couple of years, I worked trying to advocate through CMS and HHS. It's hard to gain any traction there. So it would need to be a piece of legislation that we could get passed to make those changes.
Yeah, sounds like an uphill battle, but if there's some outlets that people can get involved in, Coalition started the state agency, like the home care associations or whatever, to get involved. Definitely some homework for people listening to this podcast. You guys do a lot for the industry, and it's really cool. And I know that you offer some really interesting service programs for your patients. And I think that there's at least one of them for sure that our listeners would benefit from hearing about. Can you describe the relative caregiver program concept and what initiative you guys are involved in at MGA?
Sure. So I kind of take this question sometimes by default, because when I was at the Department of Healthcare Policy and Financing, Colorado is one of the states that has really had this program up and running, or this allowance of relative caregivers for quite some time. So kind of leading, I would say, the country, at least in the Medicaid space on that front. But generally, the relative caregiver concept it's just a service delivery model. It's kind of divided into two steps in my mind, but essentially we are acknowledging that parents are already providing some level of skilled care in the home. To Hani's point earlier, when clients are discharged, when children are discharged from the hospital, the parents are given instructions on how to care for their vent and their trach and how to do a lot of this skilled care that requires some significant training and practice. They're required to do that on their own. So we already know that they're doing it, that they're being trained to, and they're shouldering this responsibility. So the model is let's advocate to allow them to be licensed as certified nurse aides or licensed health aides, whatever the license is in the applicable state, to get them that regulated, cohesive training, make sure that they're undergoing all the same trainings that a certified nurse aide coming in to provide the care would. And then once they're licensed, trained, certified, and kind of supervised, overseen by those regulations, the second part of it is changing whatever reimbursement rules there are, or working with a payer, a private payer, to allow those parents who are now licensed caregivers to be reimbursed the regular certified nurse aide rate that they would pay a non-relative to provide. So that's kind of the concept in a nutshell. And it's a little bit, that would encompass, I guess, both consumer directed models and non. So Colorado's is actually a fee for service model that, it's just their home health benefit, and they pay CNAs to provide skilled care. There's no prohibition from that CNA being a parent, and that's kind of how Colorado left it. So that's been one option. There's consumer-directed options. There's a lot of different ways in which this plays out, depending on the regulatory framework or the payer or what's kind of happening in the state. But that's one kind of fee-for-service model is where I would say, gotten our feet wet. Is we have a heavy footprint in Colorado. A lot of our families, we have a lot of relative caregivers, relative CNAs here. And then in Arizona, we ran some legislation a couple of years ago, and then some cleanup legislation recently to get a similar program kicked off there, which is hopefully going to be actually, walking here with legs soon. They received approval from CMS, and we're kind of working with the state Medicaid agency and licensure down there to get this off the ground.
It's really cool. And speaking from a consumer standpoint, I had an employee who actually took advantage of this particular program that you're describing. There would be no other way that she would have been able to have care given to her kid or even function as a single mom if she didn't have the opportunity to have these funds, for providing that care and then upskilled to take care of her medically fragile child. So it's a really cool program. But you made a couple comments that makes me believe that this may not be something that is universally accepted across the state. So does it exist everywhere? And if not, where can people find out about it, or how can agencies get involved? Talk to me about this program. It seems like a good one for the industry.
Sure. I know it's been great for, it's got a lot of benefits. It basically, it gets parents acknowledged for doing care that's above and beyond, way above and beyond what we consider normal parental duties. I mean, these types of tasks are something that payers would be paying a licensed person to conduct if it wasn't being performed by that parent. So acknowledging that parent's capabilities, train them, and kind of have that already existing discipline of provider be able to take some of the brunt of the care that we need delivered in this nursing shortage is a great service delivery model and a great cost savings and a safe way to kind of get the right level of care in the home when we're in the middle of a public health crisis, especially. But yes, not a lot of states, have something fully up and running. We have the program in Arizona is almost there, in Colorado. And then we have a bill going forward in Florida right now. There's a pilot program in Missouri. There's legislation in Maine. So we're really gaining traction nationally, mostly by bills, mostly by legislative efforts. But there's been some cases, in Virginia, their state Medicaid agency kind of undertook it themselves, I believe, to study this, to kind of a feasibility study and see what it would look like. So just depending on the state, there might be something already underway or not, but we're definitely doing our best to kind of bring this to the states that MGA is already providing care in, and just to the country at large. So we're super passionate about it.
That's really exciting. And Hani, being a nurse, I don't know if you know if there is additional benefit. I'm assuming there would be, of having a family caregiver versus a stranger caregiver for a especially fragile child. Is there any data like that you guys have collected to support this?
There is, I would say there is unsubstantiated data currently floating around in the industry that there is a lower hospitalization rate for kids receiving services through a relative caregiver. But it's not published, it's not peer reviewed or anything like that. I would say that it is a really tough labor market right now in healthcare, and it's really tough getting nurses. And it is, when a relative caregiver is providing that care, they don't call off, they show up to work. And you don't have the same kind of struggles with client satisfaction that you do sometimes when a stranger comes into the home. We've seen when a child receives, care that's, typically delivered through, an RN or LPN in combination with relative caregivers, kind of filling in those tough to staff hours. It really is such a great model of, of care and, good outcomes. And like I mentioned, patient satisfaction, it just works. And it's really a good tool in the toolbox. It's not, in conversations that we've had, it's not like we're saying we want to get rid of private duty nursing. No, not at all. There's a place for that. Not every family, not every patient, it's not going to work, for every single patient to have either all of their care delivered through a relative caregiver or even some. It's not everybody's appropriate for that type of service. So when it can be used in conjunction, again, one of these tools in a toolbox, you can have a complete full set of tools to provide care, to keep kids at home safely and, out of the hospitals. It's just a win-win. Yeah.
It seems like it would solve a whole lot of issues, like lessen the shortage of nurses for sure, which brings me to a question that I want to ask you, but gosh, time has flown by. I only have time for one quick more question, maybe one and a half. Since you brought up the nursing shortage yourself, I am imagining that pediatrics has been impacted just with the same severity as personal care in adult, and elderly home health. What have you been doing? There's 1.5 questions. What have you guys been doing to combat that? Do you have any good ideas for people who are also experiencing that same pain that you're willing to share? And I'm sure that folks listening to this podcast will be interested in getting involved in some of these advocacy programs or things that you've got going on. And I want you to tell them how to get in touch with you before we say goodbye.
I'll say that, like I had mentioned in the beginning, I did not know about home care. And so when I had a conversation once with the governor, and he basically, when I started to give him the quick pitch of what home care was, he said, "Oh yeah, I know what it is," or "I know what private duty nursing service is," and I was very respectful, but I wanted to say, "No, you don't. I didn't even know what it was, and I worked in the NICU." So we have to do a better job at educating nursing students about an actual career in home care. There's about a quarter of a semester that's devoted. I have a daughter who's in nursing school right now, and I looked at obsessed with looking at her curriculum, and it's like a quarter of a semester, maybe even an eighth, and it's barely touches on it. So we have to do a better job at educating nursing students. Home care is a viable option. People want to receive care in the home. A pandemic has certainly shifted that move towards receiving care at home. It's a real option. It's fulfilling. It's incredible. We have to figure out a way to introduce home care as an option earlier, and that can possibly help with the workforce. And we just need to be more creative, and not even more creative. We have to ensure that licensed professionals are working to the top of their license. And so just like we talked about the relative caregiver program, we've got to start making some, real tough decisions, but clinically sound decisions on delegating care, utilizing CNAs and home health aides, even outside of a relative caregiver situation, but looking to delegate care. And because that workforce is so limited. And we're just going to have to use technology and telehealth in ways that hasn't been done before, and come up with new models of care. And, at MGA, where, we talk to payers about that. We talk to policymakers about that. We're trying to be creative because we're limited. And so we have to, do the best with what we have right now.
And there's so much to unpack in that answer that you gave. Maybe we need to do a take 2 on this, or part 2 on this. Alex, do you have anything you want to add here?
No, I'd love to do a take 2. Now that I've done a take 1, I'm already ready for my next podcast. But I think Hani mentioned it earlier, but in terms of getting involved, it is kind of a nebulous, how do you get in there as a parent or as a provider? But I think on the provider side, it's a lot easier to kind of band together. We're all providing services together and we speak. But on the parent front, if there's any family listeners, I would say, those get involved with your local community, the other parents. I know there's tons of forums for that, social media and otherwise, but get vocal, get loud, because you are the best advocate for your care. And that means coverage. That means getting rid of these administrative burdens, whatever it is that's impeding barriers to bedside, as Hani says. But yeah, I think when parents get loud and families get involved, payers listen and regulators listen, and obviously providers listen. So I think that's the best way we can effectuate change.
Awesome. So for the listeners, get involved with your state associations, with any of these other entities that will advocate, but just be loud and don't stop talking, because we got some work to do. That's my key takeaway from this conversation. And it's been lovely. There's so much more I want to talk about. So possibly we'll have a part 2 to this. But real quickly, how can people find you? Is LinkedIn a good place, or how, if they have any questions about how they can get involved with some of these initiatives you got going on?
Yeah, definitely LinkedIn. That would be great. MGAHomecare.com, but yeah, LinkedIn and email or call. It's just, as I said before, I love to hear from families. I love to hear from providers. The more voices we have, as Alex said, the louder we'll be. We are going to move. We are going to make changes. We are making changes. We're seeing progress. We have a lot more to do.
Mm-hmm. Awesome. Well, it's been a pleasure, ladies.
Likewise.
Thanks. It's been great.
Thank you for having us.
Home Health 360 is presented by AlayaCare. First off, I want to thank our amazing guests and listeners. To get more episodes, you can go to alayacare.com/Home Health 360. That's spelled Home Health 360, or search Home Health 360 on any of your favorite podcasting platforms. The easiest way to stay up to date on our new shows is to subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts. We also have a newsletter you can sign up for on alayacare.com/Home Health 360 to get alerts for new shows and more valuable content from AlayaCare right into your inbox. Thanks for listening, and we'll see you next time.